So welcome everybody to another WINCARS meeting. So today we have an interesting case discussion by Dr. Sarita Rao, who is the first to be certified in orbital hysterectomy in central India. So who better than her to present the case OCT in orbit? Over to you, Sarita. So we have the panel, Zakia, Hema, Sheba, Anupam Goel. So let's, and Dr. Jyotsna as always. Let's start and then we can have an interesting session.
I'll just share my screen. Thank you so much, Dr. Sujata. And welcome to the esteemed panel today. And let me just go to slideshow. Is it visible and am I audible?
Yes, Sarita.
So good evening, everybody. And we'll be talking about OCT in the orbit today. So basically, we know that imaging helps us in adequately preparing our vessels, deciding the vessel size, the landing zone. And most importantly, with imaging, we are also able to look at what is the morphology of the plaque to decide what is the best debulking strategy that we need to take in that particular case, especially in the case of calcified lesions, when we know frequently we get stuck when there is under expansion of the stent and we haven't prepared the bed well. And that affects our outcomes, and that leads to stent failure many of the times. So imaging helps us to have a very precise visualization and penetration in calcific disease. Calcific disease in itself is very challenging, and many a times we see in many of the trials that the presence of calcification has been associated with worse outcomes. So I'll just show a classical case vignette which brings out what is the situation. Now, this is a 76-year-old gentleman, and he's presented with dyspnea and chest pain. Now, he is diabetic and hypertensive both. His ECG has revealed a non-Q anterior MI. He is hemodynamically stable for now with bilateral crepitations. His echo was done, which showed an ejection fraction of about 25%. His creatinine was 1.2, rest labs were okay. He was taken for an angiogram, which revealed the following disease. He had an LAD proximal 90%, a mid-tubular long segment disease. Circumflex was dominant with a 70% distal disease. The RCA was non-dominant and a diffuse disease. Now, let me just go to the next image and show you. Yes, now this is the angiography of the patient. You can see the RCA is diffusely diseased, small vessel. This is circumflex dominant, and you can see the proximal LAD disease, a very tight disease over there. And you can see in this view the huge amount of angiographic calcium which is visible right from the beginning till the mid distal LAD. Lot of angiographic calcium is visible. So now we have the angiogram over here, and let's stop at this point and discuss. So what would your approach be? So from the panel, we'll have, what is your approach now when you see this angiogram? Elderly gentleman and a lot of calcified vessels. So what's your approach?
I think we should revascularize him because his ejection fraction will definitely improve with revascularization, and this proximal LAD lesion can definitely, if we do an OCT, I mean, that's probably, we can find out the calcium burden, and definitely we can go for a bifurcation strategy, whichever is applicable. I think that would be my thing, and I probably use an IABP also for this patient.
Yeah, Sarita, I think very challenging case. Elderly, reduced ejection fraction, heavily calcified vessels, left dominant circulation, and you have to deal with a bifurcation. So very, very challenging case, no doubt about it. I would have a heart team approach with the patient and the relatives and tell them that the long-term results of a CABG in depressed LV function are better than angioplasty. However, it has its own challenges. You could suffer from a stroke, and then everything goes down the drain if the patient post-CABT gets a stroke. So now that we have an advanced international procedures and good backup support for a depressed LV function, you could also offer a bifurcation stenting to this patient. Obviously, my strategy will depend on the severity of calcium, and my debulking strategy will also depend on that. Looking at the LV function, I feel doing any kind of rotablation might be very hard. We could also consider doing a calcium modification by IVL if possible. So I think the strategy will be helped by imaging. That would be my approach.
Now, very interesting comments. Yes. Anybody else?
Yeah. What about the circumflex? The circumflex, there appears to be a distal lesion, and it appears to be diffusely diseased. So yes, as Zakia has said, definitely I also would do the heart team approach. Looking at this, I'll definitely do imaging, and for the LAD, for doing the LAD, because we have to stent from the left main to the LAD. I'm very interested in what is going on in the circumflex because I would like to implant whatever stent we do in the circumflex before I come to the left main to LAD, which I will decide depending upon the imaging, what it shows, the calcification, what is the calcification. Depending on that, I will choose the debulking strategy. Anybody else?
Yeah,
Maybe the
thoroughly agreed, ma'am. I also feel that heart team approach and with these depressed LV functions and left dominant circulation, all the more given the disparity also, which appears to be there. The left main seems to be quite spacious as compared to the distal LAD, and circumflex would probably require a minimum of 2 stents. So, of course, but if we plan to go ahead with the intervention, then as you rightly said, it's an osteal lesion. So imaging techniques, and I think we discussed last session of WINCARS also, we discussed about the osteal lesion, and the choice of debulking strategy in this situation would be an issue for calcium.
Yeah, one more point to add is about the circumflex disease. If it would have been a presentation is a chronic stable angina, then I think we should consider it even for the circumflex. But the presentation is an acute and anterior MI with a depressed ejection fraction. So I think even though it is adopting the circumflex, except the protection, we may not be required to treat this. Of course, nowadays the total revascularization is coming, but that can be the staged procedure. And the second one is about what imaging. Everyone is concentrating on imaging to do it, but such a tight lesion, if you want to do the OCT, that is becomes very difficult when the distal flow is not there. So after the wiring, really, should we do a balloon dilatation and then do imaging, or directly go for the IVERS, has to be decided.
Okay, Sarita,
So-
what did you do?
This has been a very interesting discussion. Now, I have had multiple feedbacks from all of you regarding what we should do. So let's take it one by one. One was the heart team approach, which is absolutely accepted when you're doing an elderly patient. The other confounding factor in this situation is the patient's son is a pediatrician and is also the head of department in a nearby medical college, so is well versed with what is happening right here. Now, a heart team approach was taken, and everybody said that maybe we should offer him a bypass surgery, which we did. And the family, the patient's son, and the patient himself categorically refused for a bypass surgery. Now, he's a frail gentleman, elderly. The second point that we are looking at is imaging. With this huge amount of calcification, we knew that we definitely want to have some imaging. Now, whether it should be IVUS or it should be OCT, very tight lesion, as Madam has rightly said, we are a little worried about whether the bulky OCT will go in or not. But the second thing is that whenever you're dealing with a heavily calcified lesion, I always find that OCT gives me a better visualization of the calcium and helps me to plan my case better. So if I am able to take an OCT, I generally like to take it in. Yes, if I'm not able to take it in, then of course we go with an IVUS. The third thing is that which debulking strategy, of course, that will be decided totally on what the imaging gives us. Fourth thing which was under discussion is the circumflex is codominant, but there was only a 70% distal disease in the circumflex. Now the question is, this patient has come in with an acute coronary syndrome, and his entire region of the angina is the ostial LAD lesion, and that is giving him problem. So at that point, after discussion with the whole family, it was decided that we are going to do minimal to give him relief because he's so elderly, so fragile. We will settle the culprit lesion first. So that was the approach at that time. And so we went ahead and we wired the vessel and we took an OCT pullback for calcium assessment. So this was the OCT catheter being taken, and we took a pullback. You can see the amount of angiographic calcium, huge amount of it. Now, what did we find when we did the OCT? Let's look. Very interesting. So when you see the OCT, you see deep calcification at places greater than 180, at places even greater than 360. You can see the tightest area, you have 0.82. And when you go ahead, you see presence of both superficial and extensive deep calcium. Depth is almost 1.4 and at places 360. Tightest lesion, proximal LAD, MLA is only 0.82, right? So you have length greater than 5, you have a calcification arc greater than 180, you have depth 1.4. So your calcification, your score is very high. Now, when we saw all of these things, superficial, deep calcium, long length of calcium, calcific nodule over there, we decided this patient is going to require multiple therapy. Now, what will we do? It's so tight. So
can you post the OCT?
Ideal. Yes.
Can you put the previous slide again?
Okay. Now, at this point, we knew that if I take an only rota, it's going to take care of the superficial calcium. So I'll probably, and also this is a big sized vessel. So I'm going to go in with a rota and probably need to upsize it and probably also take IVL because he has deep calcium also. So now at this point,
there is a question, Sarita, whether you balloon dilated before passing OCT.
Whether I balloon dilated before passing the OCT. Actually, I did this case about 3 months ago. No, madam, I think I went straight in. It went in. I said, let me try. If it goes, fine. If not, I'll balloon dilate and try to go in. So it entered with a little difficulty. It gave me difficulty in going in, but it went.
How is the left main?
The left main was okay.
Completely
so
not.
We were able to, yes, the left main was completely okay. And the circumflex ostium was also okay. Now, at this point, what do you think we should do?
One thing
there seems to be calcification in the...
Sorry, please go ahead, Sujata.
There is calcification in the left main also, looks like, no, in that longitudinal section. Just beyond the guide, you can see. Though, okay. You saw there is some calcification there. Anyway, we are planning to stent from the left main to LAD, right?
So I want to hear from everybody what we want. What do we want to
what
do?
debulking
First,
you
bed
do.
preparation, and second, stenting. So 2 questions
yes,
now.
I will use a combination of methods if finances. If you have a pediatrician son, I would do TRIPSY, rota TRIPSY. Whether you use IVL or you said because of cost considerations, orbital. Yeah. And also because of the big lumen in the ostium. So
Madam, you think IVL will not grow upfront. So yes, you're right.
No. First do a rota and then after that
we'll take an IVL.
because look at the nodule. The nodule and We can even assess after the rota, whether be it orbital or what are the advantages. Why did you choose orbital over rota?
Yeah, I think Sarita has not yet committed that she's going to use orbital.
Yes.
Discussing
So-
right now. We are just discussing right now. I don't know. Savita, I would have even maybe put a cutting balloon first. Put a cutting balloon first and see how much a cutting balloon helps me. If a cutting balloon helps me, then maybe go in with the IVL.
Sarita, I joined late, but extraordinarily good images, excellent demonstration of the OCT images. I really love these images and beautifully demonstrated calcium nodules. Such a huge nodule. I think with orbital available, orbital is the first choice, and Sarita loves it. So, choice is orbital atherectomy first. Then, I think as Dr. Sujata said, combination maybe with IVL or cutting balloon. Once you have some disruption of this calcium, then you can figure out which one to use.
Really about this rota, I am slightly concerned about the rota is about an LV dysfunction. The patient has significant LV dysfunction, and the rota is likely to have a more of slow flow or the no flow phenomena. So, within a depressed LV dysfunction, I think with the availability of the other gadgetries in this era, I may not consider the rota as the first possibility. I think is the first we will see whether it is a balloon possible or not, and then decide about whether it is going to be then IVL or to the other modalities. The rota
Jyotsna,
is only my concern is about that.
That much calcium nodule, and I think it needs combination. We cannot avoid rota. And Rupali has already said there's a good wire bias. You can see the thing hugging. So if rota is the problem, slow flow is less with orbital. That Sarita should tell me. If that is the situation with that combination, she can use orbital.
You have any
Sarita, what's your
MCS
take?
put in, Sarita? Do you
Yes.
have a
versus
do you have a mechanical
and
cardiac
slow flow.
support?
No. I have not taken any MCS. I take access. Whenever I have a depressed LV function with a lesion like this, I take arterial access and I keep it. I keep everything ready. If I need, I'll put. If I don't need, I'll not.
You
I
put
have
a
very
4
good
French
team.
sheath. You put a 4 French sheath and keep it, or
On
just
the
a
other
wire.
side,
Yeah, just a wire or a 4 French sheath.
no, I put in a sheath and I keep a 5 French.
Okay.
So we keep a sheath and we keep, and I work with the whole team. So my team is totally trained to put in an IABP the moment it's required. I don't even have to look at that site. I just take the access and leave it. In fact, even if I don't take the access, my anesthetist will take it, or my this thing will take it. So that we have the team approach. So I simply take access. 25% for me. Usually we are able to get away with it. But yes, Dr. Jyotsna has brought out a very important point that when you rota a lesion like this, you can have tremendous amount of slow flow over there. And that is the point at which, and this RC is non-dominant. So if the left system has slow flow and shuts down at any point, we can be in trouble. That is a point well worth noting. Second thing, somebody mentioned, I don't remember who, that there's a huge nodule over there. And nodule, one, cutting balloon does not work on nodule. Second, rota doesn't work on nodule because it will only shave off the superficial portion and nothing will happen. Second, when we are talking rota, let's talk rota. So with rota, this is a 3.5 vessel. So what is the size of the burr that we are going to start with?
1.5.
Okay. So you want to
Because your
start.
OCT catheter went in, I'll go with a 1.5 burr. As
And
I
would you
said,
want to
I'll not
upgrade?
use only rota. I'll use the combination rota with
IVL.
IVL, preferably. If that is not there, at least with cutting, I'll not leave with rota. Or even if IVL, we won't leave with IVL alone. we use another high pressure. So it's now a combination.
So we agree that at this point, all of us agree that with this amount of calcification and this long segment of calcification, we know that we are going to need combination therapy. And this is exactly what I thought. So I told the son of the patient that we can do it, but I will need maybe 2 burrs because I might need to upsize my burr, and I will need maybe 2 balloons because at that time when I was doing the case, it was 80 pulses per balloon. So I said, and the cost of the therapy will come this. So cost was not really a problem in this case because there was a doctor involved and he could understand the gravity of the situation. So yes, but as a doctor, we always feel that how are we going to do the best result in the best possible cost? And how can we get away with using one therapy? Now, this is the time that orbital had just been introduced into India. And this was actually the first case of orbital that I did. Now I'm a certified proctor, but this was the first case of orbital which we did. And we especially got it for his father because we believed that with this one therapy, we would be able to tackle everything and not require a combination of therapies. So why did we think like this? One is when you use rota, you're cutting off superficial calcium, you do nothing to the nodule. So the nodule, usually you're not able to ablate. So then you take IVL because IVL will penetrate deep and break the deep calcium. With orbital, what we can do, with orbital, with a single burr, first you go with a speed of 80 and you break all the superficial. And when you want to increase further your lumen area, you increase the speed to 120. And with one burr, you can achieve both the superficial and the deep calcium. Second thing is that in this location, when we are talking about slow flow, orbital has literally no slow flow. Even in the orbital trials, they found literally no slow flow. And why is that? Because the size of the particles is very small, less than 2 with orbital. Secondly, it moves at a very slow speed, 1 millimeter per second only. With rota, we move very fast. The size of the particles are faster, and the patient frequently has a embolization, and the frequent slow flow is there. So hemodynamics vary, and we know that with patient with severe LV dysfunction, we want stable hemodynamics. So literally no slow flow, one burr solving all the problems, cost of procedure drastically reduced. So we decided, let's call for orbital. So we called for the orbital and let's see. Now, so some things which we thought rotational particularly indicated predominance of superficial calcification since the burr selectively ablates at the luminal surface. Now, by varying the ablation diameter with the rotational speed, orbital atherectomy can actually be more useful in situation where plaque preparation in larger vessels is required, or where the ablation of heavily calcified walls is required, situation in which rotational is limited by the burr side. Now, we were thinking of something to tackle superficial and deep calcium. And also in orbital, the area of ablation actually increases when you increase the rotational speed. So when you go from 80 to 120, you get a much bigger MSA. So let's see. We went ahead and we did the orbital, right? So this is the orbital inside. It takes time because you can do one run only for about 25 seconds. You'll hear the beep and you have to stop. You do not stop within the lesion. So this was orbital at 80,000 revolutions. Then after the orbital, I went ahead and did a balloon dilatation, right?
What balloon?
This was, it's a 2
Cutting
point.
or what?
I think, ma'am.
No, this was a normal balloon. It's a normal NC balloon, right? And I can see that there is still a proximal waist over there, right? So I said, okay, let me increase the speed. So I went up to 120 now. So I've hiked up at 120 and we are going in. And this is again followed by balloon dilatation. I'm still
Do
not
you
satisfied.
require first testing with the balloon, whether waste is there, and then increase the speed? Or
So we
otherwise,
tested,
you
madam.
do imaging and then see that whether you have to go for the higher speed.
Okay. So yes, we could have done that, but we decided that let me test with the balloon and see what is the situation. So elderly gentlemen, and every time I'm doing OCT, we do know that every time we do OCT, we are taking in more and more of contrast with such good images. I had used contrast in this patient. So I said, let me just test with a balloon and see how the orbital has worked. So obviously we decided that it's not worked enough. So we went in, just increased the speed, and then we said we'll take imaging. Your point is very well taken, madam, that we should take imaging because I have an OCT catheter on the table. So we did that to decide whether I need to go up to 120 or I can stop at 80. Many times with 80, the job gets done. So I went up to 100.
Why didn't you do were you against doing an IVL with the rota? With combination and with orbital, I mean.
Okay. So the cost of procedure, if you take
Okay.
rota and IVL, is about 11 lakhs.
Yeah,
At my center.
I understand, but
Cost of
upfront,
procedure.
such extensive calcification nodules, I thought a combination, or at least your NC balloon should be a cutting or something, some high
yes.
pressure, or use
Points well
NC at
taken.
very high pressures to break the base of the nodule.
Yes, absolutely. So let's look at the story and see how it unfolds. I was not particularly fond, had orbital not been available, I would have taken a combination of rota and IVL. In fact, that was what was initially offered. The whole idea behind this exercise is to get away with one therapy where we have to use two therapies. And that is the point of exploring new technologies. That is the point of having all ablative techniques in your lab. And that is the point of imaging to decide how you can get away with one technology. So this was the alternative to rota and IVL. And actually orbital works where you require rota and IVL both. You can get away with just orbital. So we went up, and yes, as suggested by Dr. Jyotsna, we imaged. So we took an OCT run, and then what did we find? So we find that yes, we have opened it up certain places, but at the tightest point, we have breaks in the calcium, but at the tightest point, we still have 1.18 only. So we went in with a cutting balloon now. As suggested by Dr. Sujata, we took a cutting balloon. Now this is a 3x10 Wolverine. Right? So the cutting was taken. The cutting opened up well. Now we went in with this is a 3.548 deployed.
Taking the Wolverine now is better than in the initial step.
Yes,
because
absolutely.
you are already created some breaks. So then Wolverine acts much better. With that much of calcium in the initial stage itself, it may not able to give that much. It is a guess. What we say is degree of the calcium to the effect. That's all.
Absolutely, madam. That is the most important thing, that cutting has to be taken at the proper point in the procedure. When you have already created cracks, when you have prepared the bed, when the cracks are already there, then taking the cutting works very well. It gives you a great dilatation and a great MSA. So, and had we taken it upfront, it would never have worked, because we know that there are only 3 or 4 atherotomes in cutting balloons, and where they will land is very questionable. But once you have created cracks, fractures, and microfractures, once you take it in, it will work. So that is exactly what we did. So we took the cutting, then we took the stent, and we deployed it. We did not do an across the left main. This was a dominant circumflex. We were able to find a stable landing zone with minimum plaque burden, and we stented from the ostium. So my circumflex is free of stent, as stented from the ostium. Now, after that, I went in and I did the post dilatation. And after that, we took the OCT. Now, what do we see in the OCT? Angiographically, it was looking quite good. OCT, now we see that at the tightest point, we only expanded 48%, and the MSA is only 4. So we know that we need to now again do something else. So now let's listen to the house and decide what would you do at this point.
No, the Rupali's question is relevant. She asked, after orbital atherectomy, have you wired the circumflex?
After orbital atherectomy, whether I wired the circumflex or not, so that's a point. Ideally, after orbital atherectomy, you should. But then at this point, majority of my job is already done. And
Sarita,
we
I
just
would
have
have
to put the
done
stent in.
prepared much more before, you know,
One
put
second.
the stent in and having an under expanded stent is an issue. So
Mhm.
maybe we should have prepared even more. I mean, it's now, see, having an area of 4,
Mhm.
it's, I mean, to the house, I would say prepare before you put the stent. Prepare to the extent, go with your cutting, go with your OPN, go with all your gadgets before rather than after. I mean, landing up in this situation of 4. So now
Very good.
I
Very
don't know.
well.
Wholeheartedly agree with Sujata. Wholeheartedly agree.
Before I'll do whatever takes to just go on doing things before. But
I need
now
to.
we are left with the option. We have an underexpanded stent. So OPNNC, what did you do? What does the house feel?
No, I think
I need to also
last time
understand,
discussion was
ma'am.
UPNNC or IVL again. Under expanded stent, people have used it.
I
Sarita
think
herself
last time the
used
same
it.
discussion has happened. That's why Sarita wanted to show it. Sarita wanted to show it that OpenNC works after the stent implantation, or IVL works after the stent implantation.
Yeah, but whatever said and done, Jyotsna, I wouldn't want to take this chance.
That's
I
true.
would prepare, go on preparing until I'm satisfied I won't put that stent in. You know,
But angiographically, it actually looks
no
overexpanded.
angiogram, Asha, in that
I
calcium.
know. That's what I'm saying. If you've not done imaging, you will think that you've done an extraordinarily good job and you would have walked out. So imaging really makes a difference in these lesions. Because
I need to
angiographically and
understand two more
Perfect.
things, ma'am.
Dr. Asha has hit the nail on the head.
Ma'am, two more things. Like initially also when we used an NC and we were ballooning, we were going across with OCT with such a left dominant system, would you prefer to keep a wire right from the very beginning, not just after orbital arthrectomy? And the second thing is an upfront temporary pacing must every time we go in for these procedures?
Okay,
Two things.
very good questions. Now I'll tell you. I cannot keep a wire in the circumflex when I'm doing orbital. It'll just shave it off. So
No,
till
but prior
I
to
finish
that
my
also, no?
orbital, I cannot.
After.
That's the point. Let me
Prior.
complete. So till I have finished the orbital, I can't keep a wire in the circ. One, and especially since I'm burring from the ostium. So you can't use the orbital when you have a wire in the circ. One. Second is, once I have finished burring and I have a stable bed over there, no slow flow, stable hemodynamics, all I am left to do is put the stent. Why would I, at that stage of my procedure, when I have nothing left to do, just put the stent and come out? Will I want to put it into the circumflex? The circumflex we always protect when we are doing rest of the job, like we are ballooning, we are cutting, we are using IVL, we are using all those things. That's the point. I have a free ostium of circumflex, and till my orbital is over, I cannot wire the circumflex. So then why will I want to wire it when my patient is stable, when all I'm doing now is just put the stent and come out? So that's why we did that. Second question, Dr. Shiba, very important. You asked one second question was
an upfront temporary pacing.
Yes, that is again important. You are very right. Many times when I rota, I take upfront LV dysfunction. If I'm doing LAD or RCA many times, and I'm rotating, I try to put in the TPI, or at least I take a venous access. This is the difference between rota and orbital. Orbital, literally no slow flow and literally no bradycardia. If you read up about it, orbital atherectomy is associated with literally no bradycardia, and rota is associated with higher rates of bradycardia and higher rates of slow flow. So I did my entire homework and research, and I knew that this patient is not going to have slow flow, is not going to have bradycardia, because orbital doesn't produce either
Temporary
of these
pacemaker
things.
is, the TPI
Why
lead
did you
is
put
there.
a temporary?
I think TPI is more often now put only in RCA. If you are doing a rota
Yeah.
of RCA,
Why
then
did you put a temporary now?
people recommend, otherwise not for the left. That's what I think.
We are using aminophylline infusion. Okay.
Sarita, can you show across the, yeah, you're showing the cross section
Now let's see.
across the
So I have
LCX.
significant
Yeah.
under expansion of only 49%. And let's see what we did. And we have an MSA of 4. Nobody is happy. I'm not happy. The house is not happy at all. Now let us see whether
can you show
orbital
across
worked or not.
the LCX, the circumflex, the struts?
So
Do you
let me
have that? Do you have
whether
that?
I
don't-
3D?
still,
3D?
Sarita,
No,
whatever.
I don't have the 3D right now.
Okay.
But yes, Dr. Sujata?
I will not take the chance of not wiring the circumflex.
Okay, so I was placing from the ostium. I didn't
Right.
wire, but it's a personal choice.
But
It's an
yes,
operator
yes.
choice. If you
I'm
wire, I'm happy with it. So it's
I'm
an
putting
operator
my
choice.
I'm being the devil's advocate. I'm thinking that so wire in the
Something will go wrong at this point.
Yeah.
Okay. So now let's see what happened. So this is the situation under expansion.
Sarita, I think we have to take that point that is wiring of the circumflex is a mandatory, because till you finish the whole job, you can't say that you're out of the danger.
And
So
that
that
is a
is a
dominant
mandatory.
circumflex. It's not a small circumflex.
So yes, you can definitely wire if you feel that there is something you might have an issue, then you can definitely wire. And frequently that is usually what we follow, that we wire LAD and circumflex both when we are doing such lesions. But at this situation, I felt that, okay, all I have to do is put in the stent, and I stopped. So
How much was the landing zone, ma'am? How much was the landing zone at the, ostium of the LAD? Because the way the lesion appeared to be, even, I thought that.
nervous
If you
about
look at
that,
the iliocaudal views, if you look at the caudal view, you'll find that we had a landing zone over there, which is why
I'm nervous about that also, Sarita. I'm
Don't worry.
nervous about the nailing the ostium. I would definitely
So-
prefer to stand from left main to LAD.
Okay. So that's
The other
again
viewpoint.
another choice which you have. You can do that. But for me, it was a dominant circ. I did not want to. And I found a landing zone, so I didn't. And then we took in a balloon and we dilated. Okay.
Okay.
We simply used an NC balloon and dilated, and then we took the OCT. Now, this is the OCT. After dilating just with a simple NC balloon. My MSC has gone up to 10. My expansion is
radius
now
are
96%.
But did the stent lengthen a bit and come across your circumflex ostium?
No.
Because
You can
in that, what do you call? Because once you lengthen, once you do a dilatation with a higher balloon, like you did with a 4/8, the stent will lengthen. So
you're talking about longitudinal stent deformation.
No. The little, it will lengthen a bit. I will post in the group.
So we took images. We took OCT runs final. The circumflex ostium was totally free, clean.
Because in the longitudinal view, aren't there struts across? Just did you do the longitudinal 3D view?
We did. We took all
Can
the
you show
images.
that?
In fact, when we were doing that, we also had an OCT expert in the lab, because it was a doctor's father and I didn't want any mistake. So we checked that, and the circumflex ostium remained totally free. And we had enough landing zone at the ostium to place the stent well. Otherwise, we wouldn't have taken a chance.
No, you've written the well-expanded stent at LMCA.
Yes.
So the stent is across.
No. No, that is a mistake. We kept it there only at the ostium. That is a mistake in the printing. Now let us look at this picture. So this is pre, we had 0.8, then post-orbital, we had 1.13. Post-PCI, we ended up with 4. Post-high pressure NC, we ended up with an MLA of 10.09 and lumen diameter of 3.55. And this was the final images.
It looks great
Oh.
result. I will definitely be happy with it.
What is the opinion of the rest of the house? Now, are you happy with the result?
I'm happy.
Thank
I'm
you.
happy,
Dr.
but I have reservations.
Result is
Jyoti,
excellent. Result
There
is
is
excellent.
there is some still under expansion at the ostium.
I am not worried about that. I
Plus,
strongly have a feeling that there are struts across the circumflex. So I'm worried about that future. But for now, we are saved. Let's go home. Okay.
Okay.
One more thing, Sarita, when you have such short, under expansion, there are operators who are now using pot balloons. The pot balloons are designed in such a way that they take high pressure. So
Yes.
you take short pot balloon, it
Hmm.
really helps you to, just cover that part.
I think
Yes,
this time
we did take,
Yeah.
actually, Dr. Zakia,
Yeah.
in this case, I did take a pot balloon.
Mm.
At that under
Okay,
expanded
4.8.
area, we did take a pot balloon over there.
So how is a pot balloon different in its dynamics from a routine NC or this thing, ma'am?
Okay, so pot balloon is very interesting. You have a dedicated pot balloon now, right?
Yeah.
It has no shoulders.
no
There are no
overhang.
shoulders to that balloon. There's no overhang. And you have a 4, you have a 4.5, and there are no shoulders. So no overhang into the vessel. Exactly at that point that you want to give, you can give it at that point. Since it's a smaller sized balloon with no overhang, you can give high pressures at that point with perfect expansion and very less risk of dissection.
And what Ziad Ali was telling this imaging conference was that if you have a very calcific lesion, your expansion is reasonable, anything above 80%. You've gone up to appropriate NC balloon up to 22 atmospheres. Stop there. Don't
Yes.
overdo it. That can
Yeah,
result in greater
I
problems.
totally
So
agree.
I think should accept. She's got 90% expansion, 89%. And
Yeah.
Timmy 3 flow, it's looking good angiographically. It's looking good, good lumen area. I think we should leave and stop there. Not go on trying for perfection and result in a perforation. That will be
No.
it will
We
spoil
don't want to
everything.
do anything now, Asha.
Absolutely.
We didn't want to do. We don't want to do anything
Your
now.
point is well taken that you should have prepared the bed much better.
Yeah,
Maybe a cutting balloon in the.
Sarita, any 3-day views of the circumflex did you take
We have taken, but it's not in this
in
presentation.
this presentation?
I will send you in the group.
Yeah, sure. Okay.
I
So
don't-
we had taken all the views.
Sarita, your left main was roomy. I
Yes.
would
Yeah.
still prefer to come in the left main. I don't
Yeah.
think your LCX would have got compromised.
Yeah.
Doing
Yeah.
a little left main
Yeah,
over
it's
LED
easier.
has far
Future
better
is
results
easier
than
with
bringing
left main to LED, which I've
Yeah,
always.
I feel nothing would have happened to your LCX. Your LCX is fine. Even
And
if
you will be able to access it better in the future.
and your ostial LED preparation would have been much better. You would have come more into the left main and prepared it much better is what I think. But in the end, result is very good.
Result is good. That's
Very
what
good.
matters.
in the end also, and otherwise also, all said and done, that I think when you have a left circumflex, which is, left dominant circulation, and thoroughly agreed that landing zone was a matter of concern, but at the same time, this left circumflex was also too big, and once you are dealing, that you never know. So, but
Very
yes,
good point.
very,
I agree with
You're
Dr.
the best
Shida.
judge on the table.
So
right?
most
Yeah, once
importantly,
the
when I'm
patient is
doing
on
dominant
table,
circ,
yeah.
I don't like to go left main to LAD. Now, contrary to what is the popular belief that most people like to stent from left main to LAD, because technically that is much easier to do. I have a long series of patients whom I've stented from ostial LAD, and I've taken routine check shoots for them at 1 year, and they're doing really well. So for me, I still do a lot of ostial LAD placement, although the popular belief is now that you go from left main to LAD, you're able to prep better. But for me, dominant circumflex with a distal circumflex lesion, which I might need to intervene in the future, I would have had to go through the left main to LAD stent, and I would have had to distort it. So for me, leaving that opening of the circ free from the future intervention, if required. There's a very big if, because that would probably remain stable. But if it did not, for me, that's open. Also, I did find a landing zone. And since I was using imaging, I was very clear that my landing zone was good. So I did find a landing zone, and I preferred to keep it there. Thirdly, regarding vessel preparation, when I had used orbital atherectomy and I had gone to both the speeds, 80 and 120, and I had spent a good amount of time prepping the vessel, then I had followed it up with an NC balloon and a cutting balloon. And when your cutting balloon is opening up beautifully, you are very clear that you have created the fractures because you've looked in two orthogonal views, you've seen the expansion, you know that there are fractures, you know that there are micro fractures, and this is going to open up with just a little dilatation. So I felt safe at that point and going in and putting in the stent, because I knew, because with the stent balloon, we only give nominal pressures. I knew the moment I gave in a high pressure over there, my stent is going to open up beautifully. So I was very sure at that point that this is going to open up. And I know that I've only given nominal pressures with the stent balloon. The moment I give high pressure, it's going to open up. So you have to have that degree of confidence in the tool that you're using, also because you've imaged. Then you followed it up with a balloon dilatation. You've looked into orthogonal views. You know that the lesion is opening up. You just need to give the pressure and make the metal accommodate into that. So, use of orbital atherectomy and cutting balloon for bed preparation for stent implantation, in this case, was well appreciated. Still, we ended up in a slightly underexpanded stent, which was dealt with adequate post-dilatation. The interpretation of deep calcium, the appreciation of edge dissection, the expansion opposition, all very well appreciated by OCT. It was a boon to have it on the table. Prior imaging helped us in planning the treatment, the type of plate modification strategy, because it required something to deal with both the superficial and the deep calcium. So our strategy became very clear by using OCT. So it's apt to say at this point that OCT put us in the orbit. Ladies and gentlemen, thank you so much.
Superstar.
Excellent case, Sarita. Even I agree that about the nostril LED stunting, because especially when you did the imaging, then you can be much more confident. You are excluded the left main disease. Yes, I definitely agree that yes, you can put it. Even though everyone says that, they say that angiocardiography we don't see the left main. That's why better to come to the left main. But as you said it, if it is there is a landing zone and imaging is approved that there is no left main disease, I agree that osteal implantation is still well accepted. Only thing is bed preparation. As you said, final result you are able to get the good one. So it's an excellent case. Really requires a claps because of the way you demonstrated, the way you have done courageously.
Congratulations and nice case. So any more comments from the panelists?
It's a very difficult case, I would say, but done very nicely. That's good. And it's very rightly used, the OCT, relatively new technique, used to its full benefit, and the result looks very good.
So,
Thank you, Dr.
how would
Nidhi.
you have done, Dr. Sujata? Would you have used an OPN or an IVL in addition to
See,
orbital?
I'm not rich like Sarita, you know, my patients are all extremely poor and financial problems. I would have done a rota with cutting, as I use rota cutting. But no financial problems, I would have used orbital and maybe I would have used an IVL. Because in the end, you will be even more happy, right?
So for the benefit of discussion that we are discussing orbital arthrectomy, Sarita ma'am, where are the cases when we should not be using orbital arthrectomy in patients with calcified lesions? The
Okay.
smaller vessels, the
That's
tortuous
good.
vessels.
Small vessels, avoid orbital, and tortuous vessels, avoid orbital. Orbital is much suited to straighter segments. If you
Especially
have
ostia. Is it true, Sarita?
No, for ostium, there are two things. Now, traditionally, rota ablation has been preferred for ostial lesions, but there is a very big advantage of orbital in ostial lesion. And why people use orbital in ostial lesion is because you can burr backwards. So they say,
you told me.
if you can just go through the lesion and then pull because it has cutting at both the forward and the backward, while the traditional rota which we have has got burring only in one direction. But with orbital, you can burr forwards, you can burr backwards. I frequently take the orbital across and then I pull it back. So much easier to control. Pulling back the burr is very easy to control. And going forward with the burr is sometimes it jumps. When you're pulling back, it comes very easily. So burr forward, burr backward is both possible with orbital, and which is why it can be used in orbital. You just go across the lesion and you burr back.
Okay.
And that's why
fact,
it gets
I had
stuck
my
much less
concerns.
also.
Yeah, but then there have been two papers which have, read about the ostial as well as the aorto-ostial lesions, both for RCA as well as LAD.
Aorto-ostial lesions are traditionally better with rota.
Yeah.
Yes.
So, but
if you can cross it and then pull back, then orbital is also a good choice.
I came across two papers, which mentioned that the real world practice did not find significant differences in MACE. I'll also be sharing them in the group once you've shared your images, ma'am.
So, there's only one big risk with the orbital. That is the risk of perforation. And you know why that occurs?
Yes.
Because people forget that when you are going like this, see, rota goes straight like this and orbital goes like this. It's like a lasso. Now, if you have a dissection, both of these techniques produce dissection. But with rota, even when you have a dissection, your burr is moving forward and backward. With an orbital, the moment you have a dissection, you stop. Why? Because it will find the dissection and it will go deeper into it because it's moving like this. So the moment it finds a dissection, it will burr inside the dissection and you will have a perf on table. So when you're using orbital, take frequent checks to see, have you created dissection? The moment you see a significant dissection, stop orbiting. Your job is done. Please come out because now the safety is at question. So orbital needs very, very vigilant operators is what I will say, because you can have a perf. With rota, the perf is less, but the slow flow is phenomenal. With rota, bradycardia is there, hemodynamic changes are there, slow flow is there. With orbital, no slow flow, no bradycardia, no hemodynamic changes, but the risk of perf is there. Moment you have a dissection, stop. You can't do it.
Sarita, I have a question. So, do you think, let's say we have no financial issues at all, would you do only orbital and forget rota?
Absolutely. I have all three. I have rota, I have orbital, and I have IVL. In fact, just now, I have done an orbital case and cup. I had a left main disease extending all the way to mid LAD and long segment disease. For me, it required actually 2 stents because the 48 became short. So I had to take 2 stents, a 33, and I think the second one which I took was what? 26. Yes. So I orbited right from the left main into the LAD. And beautifully, no slow flow, no change in hemodynamics. This was a patient, again, with LV dysfunction. This is a patient with creatinine levels higher. So I had to take in an IVUS rather than an OCT. And stable, the case went stable, totally rock stable.
So I haven't used orbital at all.
You
So
should.
it's
Haven't used so far. Haven't used it.
mm.
Good
So
case.
with the class, I'll definitely call you up and then we'll.
Yeah.
So it's been an interesting discussion, a lovely case, and as usual, done courageously by Sarita and presented wonderfully. So, with I thank all the panel members and the audience for making time. I think it is our pleasure listening to the case, and I request more people to join in because everything is a learning point here. Thank you, one and all.
Thank you.
Thank you.
Thank
and
you
good
so
night.
much, everyone.